Good afternoon, and thank you for taking the time to join us for this webinar. My name is Shanti Singh Anthony, Knowledge Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS, based in Georgetown, and I am pleased to be your moderator for today's webinar. Let me extend to you a warm welcome on behalf of PANCAP's Director, Mr. Derek Springer, and thank you in advance for joining us. PANCAP continues to serve as the knowledge coordinator for the region, and through this forum, we're pleased to share new evidence-based clinical and public health research updates and promising practices and successful interventions in the HIV response. Through this forum, we also facilitate a greater understanding of the barriers, challenges, and gaps in the regional response, and moreover, we propose recommendations for addressing these. With that as a background, a few logistic and operational points to note before we get into the presentation. Firstly, your mics are muted. If you have questions as the presentation progresses, please note those down in the sidebar. We will address them during the question and answer segment at the end. Secondly, in relation to the flow, we will take our two presenters today, and this will be followed by the question and answer segment. And again, please type your questions in. Finally, the webinar will be recorded and shared on PANCAP's website for the benefit of the greater partnership. Today, we'll be hearing from Guyana, and specifically from Dr. Rhonda, the National AIDS Program Manager, and Dr. Ruth Ramos, Director of the National Care and Treatment Center. They will be sharing on their experiences with TB/HIV management in Guyana. Dr. Rhonda is a medical doctor who has, over the last 5 years, been integrally involved in HIV management. She is currently the National AIDS Program Manager and has been in that position for almost 2 years. She has responsibility for coordinating the national response, including addressing the enabling environment, prevention of HIV, care, treatment, and support services for people living with HIV, strategic information on HIV, and all other aspects of the Guyana's response. I will go ahead and introduce Dr. Ruth Ramos. She is the medical director of the National Care and Treatment Center, the largest HIV treatment site in Guyana. She has dedicated all of her professional life to HIV management and has been managing HIV patients for the past 15 years. She serves as the director of the National Care and Treatment Center and has been in that position for the past 6 years. She is also very highly experienced in the management of persons with TB and HIV co-infection. I now hand you over to firstly to Dr. Rhonda and then to Dr. Ruth Ramos, who will share with you their experiences on HIV-TB co-infection management in Guyana.
Thank you very much, Dr. Singh, and good afternoon, one and all. Today, it's indeed an honor for both myself and Dr. Ramos to be at this forum sharing with you our experience in managing TB/HIV patients here in our country. So Dr. Ramos and I will do the presentation in two parts. So I will address as you would notice in the outline, an overview of programmatic activities for TB/HIV co-management, screening of the TB patient screening for TB in the HIV patients, and implementation of the 3 I's. At the end, I will wrap up with sharing with you the reporting tools that we use at our treatment center. So as it relates to TB/HIV program activities, so the National AIDS Program Secretariat and our National TB program, what we actually do in order to ensure that we are consistent as it relates to our management and what we do for our patients, we would normally plan collaborative meetings. At these meetings, we're able to share the outcome of patients. We're able to discuss IPT uptake, which for us has been a challenge over the last few years. And we also collaborate as it relates to training our healthcare workers. There's data sharing amongst the two between the two programs, and we use this opportunity to triangulate our data that is collected to ensure that we are consistent with what is reported. We also conduct clinical chart reviews, and in so doing, we would regularly assess that screening is done for all of our patients at the treatment site as it relates to screening for TB. Some of the new activities that we plan to have moving forward to increase our uptake in IPT or isoniazide prevention therapy is having training in infection control done across our sites that would not have been exposed to this level of training, as well as training in the diagnosis of TB. We also intend to embark on collaborative home visits. We intend to collaborate in our supervisory visits, as well as share the task of reporting and monitoring our IPT uptake at the treatment sites. Currently, the National TB Program takes ownership of this activity, but moving forward, the National AIDS Program Secretariat will also play a vital role in this. So screening for the patients with TB. So there's an algorithm that both programs share, one that we use for screening of children and the other that we use for screening of other patients, of the adult patients. So in terms of screening of the children, what we would normally do is begin by doing a clinical screening, looking for coughing, fever, weight loss, or any history of a contact with a TB case. Once this is so, then we would move on to do the further investigations for TB, but at the same time try to rule out other illnesses that can cause these same symptoms. Once we've confirmed that it is not TB, then we would follow up with that patient and consider initiation of IPT. If it's another illness or respiratory illness that's causing the symptoms, then we would give the appropriate treatment, but we will continue to monitor that patient to ensure that we are not dealing with a TB infection. As it relates to the same screening method, if we find that they don't have any of these clinical signs, then we continue the assessment. We ensure that there is no contraindication to IPT. If there isn't, then we consider IPT. And if there is, then we defer the IPT treatment, but we continue to closely monitor that child. In terms of screening for adults and adolescents, we try to categorize the patients according to risk. And so if the patient is considered a prisoner, homeless, diabetic, patient under 15 years old, or has a low CD4 count, then for that person doing the clinical assessment, once we find that they have symptoms, then we continue by screening through Gene Expert, or we do a fast the sputum smear test. And once that test is negative, then we would consider the patient for IPT. If the test proves to be positive, then that patient is referred out to our TB site for TB management. In screening, if we don't notice the patient to be high risk, but however the patient has cough, fever, night sweat, or weight loss, then again we screen for TB. Once we find that it's TB positive, then they're referred for treatment. If it's TB negative, then we would do the TST. And once the TST is 5 millimeters or above, then we would place that person on IPT. If it is under 5 millimeter, then no IPT is given, and we continue to screen each visit for that patient. If there are no symptoms, then we would do the TST. And again, if the TST is above 5 millimeters, then that person is placed on IPT. And if it is under 5 millimeters, then no isoniazid prevention therapy is done, and we continue to do the screening method for that patient. So in terms of increasing our uptake of IPT and case finding, we do it by the method of implementation of the 3 I's. This is what is recommended by the WHO. And so in so doing, what we actually do is try to do intensified TB case finding. And in order to do this, we do assessment of TB status of all HIV positive patients. This is done on every visit at the clinical site. And later down in the presentation, you see the tool that we use to capture this information. We also ensure that each site has a register, so the screening can be recorded that it has been done. And we should have a personnel identified at the site that is responsible for ensuring that TST is done, and then for monitoring same. In terms of monitoring of the register and ensuring that the register is complete, the TB program continues to play a vital role in assisting our care and treatment sites in ensuring that that is done. Moving forward, like I would have mentioned in the earlier slide, one of the new activities would be for the National AIDS Program to also play a vital role in ensuring that these registers are completed. In terms of the isoniazid prevention therapy, what is measured by the TB program is the availability of TST at that site, how often it is available to the site, and whether the patients have to return to that same site to do the readoff. And why we look at whether or not the patient has to return to the same site is because if you know Guyana and our geographical setup, some patients find it challenging to return to their specific treatment site to have TST read off. And this in itself can result in a test not being read and then eventually a patient not being placed on IPT. So if the patient doesn't have the possibility of returning at that specific treatment site to have the TST read off, then the site tries to put other arrangements in place in the sense of looking at within your neighborhood, whether there's a health center within the vicinity of where you live that you can access there, and whether there's a personnel at that health center that has the ability to read off a TST. And so then that person will assist in the read off, and then the patient will return with the reading at the next visit. In terms of infection control within our HIV healthcare setting, so infection control, this also is monitored by our TB or partners from the National TB Program. They would have, the basis of this or the foundation of this would have lied in the standard operating procedure that was developed by our Standards and Technical Services Department. And so for the infection control, the TB program, what they do is assess whether or not the site has a committee set up, whether there's a focal point or a personnel identified as responsible for ensuring that infection control is practiced, and whether where co-infected patients from this, where are the co-infected patients from the site treated. So in other words, they look at whether or not your co-infected patients remain in your HIV care clinical setting with your other patients who are non-TB. And usually for Guyana, we don't practice having the patients being managed in the same area. So they're usually referred out to the chest clinic. It may be in an entirely different building, or it may be in the same building, but in a different part of that building. We also check to see that the site has a register and that register is updated and a personnel is identified as being responsible for maintaining that register. The ventilation of the site is also assessed, and whether or not clients within the waiting area that are suspected to be TB patients are fast-tracked through the clinic. This is sometimes a challenge at some of our healthcare facilities, ensuring that these persons are fast-tracked. But what we would have done was to encourage the staff, all of them, not just those that are part of the infection control committee, to be very vigilant and observant in noting if persons are coughing in the waiting area and appear to be ill, and ensure that that person is fast tracked through the clinic. And we do the necessary screening so we limit the exposure of other persons there. They also assess whether there's the availability of surgical mask or tissue for patients who are coughing within the waiting area and may be suspected to be TB patients. So this is where I take a break, and Dr. Ramos will now join you to talk about what we do in terms of initiation of ART in our TB patients.
Good afternoon. I will briefly tell you of what's been done in Guyana with HIV-TB co-infected patients. So we follow in WHO recommendations and recommended that all HIV-TB co-infected patients should be placed on cotramoxazole prophylaxis regardless of the CD4 count. That's been based on studies that we know that there is a better response to the tuberculosis treatment when the patients are using cotramoxazole prophylaxis. All TB patients diagnosed with HIV should be on HART regardless of CD4 count, and all HIV patients diagnosed with TB should be on HART. Our preferred regime will be tenofovir and tricitabine with efavirenz that we do in a fixed dose combination. We normally call it a triplet. It's a simple drug that is all over the Caribbean, and this is our preferred regime. But we could have alternative regimes for patients with other comorbidities or renal impairment or other things that they can use the tenofovir with using sidovudine with lamivudine and efavirenz. We have some time to modify the regimes if it's necessary. If the patient has been using a combination that includes nevirapine, we will substitute nevirapine with efavirenz, or if the patient can't tolerate the efavirenz, for some reason this patient have not been using efavirenz, we are substituting the rifampicin with rifabutin. For those who are in second line, which our second line includes lopinavir, ritonavir with tenofovir and tricitabine and ACT, we substitute rifampicin with rifabutin. And these are because of the enzymes that are induced by rifampicin that will decrease significantly the absorption of nevirapine and the lopinavir, ritonavir, and therefore will cause failure of the patients. Our aim is to initiate her 2 weeks after TB treatment. Every case is evaluated on a personal way. And as soon as the patient tolerates TB medications and there is no toxicity, the patient is introduced to the regime, the preferable regime or the alternative regime. For patients who are hesitant to start continuous counseling, and for those who have liver toxicity, then we monitor them continuously until the patient is stable and we are able to start antiretrovirals as soon as possible. This is all for my antiretroviral presentation. Dr. Moore will continue with us presenting some reporting tools in HIV and TB monitoring.
Thank you, Dr. Ramos. So there are two fundamental tools that we use. One is used to report from the facility to the national program, and this is the form that we're looking at currently. This was an addendum that we made to our current care and treatment reporting tool, and so we try to capture in here all information on HIV and TB. So if you look at the fourth table, at table 4, this is where we collect information on the number of adults and children enrolled in the HIV care setting, whether they're on treatment or not, who had a TB status assessed during the during the last visit. This is something that we have to report on a monthly basis, and it's our measure of looking at one of our 3Is where we're doing intensive case finding. The next thing that we collect is the number of HIV positive patients that are newly started on INH prevention therapy during the last month. And we also collect information on the total number of HIV positive patients receiving INH prevention therapy at the end of that particular month that we're reporting. So this information helps to guide us as to where our challenges are as it relates to intensive case finding and our uptake in IPT. And I can tell you that the uptake in IPT has been a challenge for the program. What we would have noted, and this essentially came out in our collaborative meeting that we had just only 2 days ago, some of the doctors are actually hesitant to initiate the patients on IPT, or sometimes they're in a setting where it's not immediately available renal function test or liver function test for them to make that decision to put the patient on INH. And so with not having the necessary laboratory tests immediately available to them to ensure that the kidney and the liver of that patient is in a healthy condition to support the INH therapy, some doctors are hesitant to do so. So we have a lot of work to do to ensure that these patients are placed on IPT, especially after having done a TST and that TST shows more than 5 mn or reactive, and that patient should be placed on prevention therapy once the TB disease is ruled out. So the next reporting tool that is used, or the next tool that is used, is one that we use when the patient is visiting with the doctor, and this is the information that we would normally collect. And if you notice, one of our columns address TB status and PPD result. And in this, the C stands for cough, the W and the L stands for weight loss, night sweat. We also assess for fever. And so this is a way to remind our physicians that you need to be collecting this information on each and every visit for the client. And it has, we think, has really helped in ensuring that the information is documented, because it's not only about asking the patient whether or not they have those symptoms, but that information must be documented. If that information is not documented on this particular form, which is a part of the patient's chart, then it does not transition to the data source or the register where we would now report on the national numbers. So even if the doctor may have asked this or done the necessary screening, once it's not recorded, then that patient is not counted as one who would have been screened at that visit. So we really stress with our physicians the importance of practicing good documentation when reviewing the clients at the clinic. So these are the two major forms that we use in doing our in capturing our information as it relates specifically to TB HIV co-management. So this brings to the end our presentation, and we're open to questions that you may have as it relates to what we do here in Guyana for TB HIV co-management.
Okay, thank you very much, Dr. Ruth, Ramos, and Dr. Rhonda Moore, for what I think it's quite a comprehensive a comprehensive presentation, I'm sorry, that really captures some of the efforts and some of the interventions Guyana has put in place in relation to testing HIV patients for TB, addressing prevention of TB among HIV patients, including some of what they've been doing in relation to their infection control practices and IPT prophylaxis for persons with TB infection. Thanks, Dr. Ramos, for sharing on how you manage patients with TB HIV co-infection, some of the nuances around ART regimens. And thank you to Dr. Rhonda Moore for talking about the clinical and programmatic monitoring and evaluation you do around the TB program. I saw that one of our participants had her hand up. I am kindly asking if you have a question that you type the question in. We will respond to your question. But at this point, I wanted to ask a few questions myself. And so my first question had to do with the slide you presented up more on that spoke to the algorithm for testing children for TB infection, right? HIV children for TB infection. And my question is really, if we can go back to that slide, yes. My question really is, how do you define children? And I'm asking this in the context of Guyana having, I would say, almost 100% coverage with BCG. And so how do you define children in an algorithm like this? I think this was the one here.
Yes, so for us here in Guyana, once the child is between the ages of 0 to 14 years old, then we would classify them in our HIV program to the children. From 15 years and beyond, then we classify as adults.
Would a child with a BCG vaccine be considered in this algorithm? And if yes, from what point?
So a child on BCG would not be considered in this algorithm because they're considered to have coverage. And so we would be looking from around age 5 onwards to screen that child.
All right, thank you so much, Dr. Moore. And I'm asking again the persons who have raised their hands if they can type their questions in. I had a question to both Dr. Moore and to Dr. Ramos, sort of linked to the slides that they have presented. So in your next slide here, Dr. Moore, you did share that when you try to define who your high-risk population is for TB screening among people living with HIV, I think it's great that you're very specific in pulling these out. So it's your prisoner, homeless people, diabetic, under 15, and persons with low CD4 count of 500. And like I said, I think it's great that you can really be very specific about these. But we know that a lot of patients who show up with TB will oftentimes have CD4s that's greater than 500. And so I'm wondering if that has come into the consideration when you put this algorithm together. And then linked to that, I had a question for Dr. Ramos. So for Dr. Ramos, as she presented on treatment, and we know that there is this push, and Guyana has been on board with this push to have persons starting treatment as early as possible, particularly persons with TB HIV co-infection. But how much of immune reconstitution have you seen with that early push for treatment? And slightly different question, but related. What would be, and you may not have an answer, but what would be the average CD4 count that patients are coming in with? Is it going up? Are people more aware? And so once diagnosed, they're coming into treatment earlier? Or are we still having persons coming in with low CD4 count? And therefore you see the immune reconstitution syndrome that I'm asking about.
Okay, for the first question, the one that you say about how much immune reconstitution we see. As we start patients earlier, we are seeing less problems because these patients tend to present and show signs and symptoms of TB with high CD4. We have issues with those who present late with low CD4 that we cannot make a diagnosis of TB, and then after initiation, they immediately constitute. For the second question,
the first question was whether the consideration...
the CD4, the presentation. I think long ago we used to have people presenting very, very, very late. We have through the years a big improvement, and we were receiving patients with high CD4, knowing their status. Lately, we have seen kind of a mixture. We've seen people who come early, but we have seen again outbursts of people who come in late. Either they knew their status long and they went into hiding and now coming when they are sick. So we have a little bit of disappointment. Like for the past maybe year or 2 years, seeing back people who are presenting with CD4 less than 50, and also they knew their status. So we still have to emphasize that every level, wherever a person access medical care for any reason, chronic diseases, anything, at HIV test should be offered, so people will know the status.
Thank you so much. We have a question from one of our attendees who is asking whether Dr. Moore, your system is an electronic reporting system. And I will probably add to the question, and if it isn't, how much of a level of effort do you need to really have a good paper-based system like this?
Thank you very much for the question. No, our system currently it's not electronic. It is a paper-based system, so it takes a lot of effort and at least 3 staff to ensure that we have all our data collected and verified before it is reported as the final numbers. So it takes us a little bit more time than it would if you had an electronic-based reporting system.
So we have another question that has just come in. What is defined as a first clinic visit? Because sometimes patient gets in for one complaint and then the next visit is a follow-up for a result. Is that considered a new visit in your system?
Yes, so in our system, each visit is considered. Each visit is not considered as a new visit. Your new visit, yes. So each visit is considered as a new visit, and it is counted. And on each visit, the person is screened for TB.
Okay, so great. I wanted to ask this question though in terms of the WHO symptomology, because there has been a really great push from WHO to really be able to place persons on IPT prophylaxis without going through TST, because tuberculin skin test has its own challenges and many challenges. And I know that on one of your slides you did say that one of the parameters that the TB program is monitoring is return rates for readoff. So what's the program's thinking in terms of really moving forward with using WHO symptomology for screening TB, no TB, IPT?
So the national TB program is really inclined to going towards what WHO is now recommending. Like I had mentioned in my presentation, some of the hesitance actually come from the doctors in the clinical HIV setting. And this I'm reporting based on what the TB program has indicated. In the month of, I believe it was January, they had started collecting information from the sites as it relates to patients being placed on IPT and what were the reasons why persons who would have had reactive skin tests not placed on. And so it's definitely, it definitely demonstrated that there was a hesitance. And so I foresee that although the program wants to move in the direction of having the persons placed on IPT according to WHO's current recommendations, that it is going to be a challenge to get the buy-in on the end of the clinicians in the HIV clinical setting. But it's something that the National TB Program is looking at doing.
Okay, we have 2 more questions that have come in. Firstly, is there one central HIV treatment management center?
I can try to answer that. Initially, early 2000, we were centralized. But very soon, the program was decentralized and many treatment sites have been opened, and currently we have 20, 22 treatment sites in the country. There are challenges because Guyana is a large country in comparison with the population, and people are scattered into the hinterland area, and sometimes there are few patients who are there and giving access to them to ARV. But we have several treatment sites around. We have a reference center that is where I work, that the difficult cases, the training for the doctors is done through the National Care and Treatment Center, but all of the others will deal with patients at different areas in the country.
Thank you, Dr. Ramos. There's one more question. How many sites are there for screening of people living with HIV for TB in Guyana?
So for people living with HIV, it would be the same 22 sites because they would be attending those sites and screen there. But there are additional TB sites beyond the 22 sites where screening is done, and this is also present in the primary health care setting as well.
Yeah, so we have a few more questions. I think this sounds to me like a sort of a monitoring and evaluation question, but the attendee is asking, does the patient have to be screened for all visits to be counted?
Yes, the patient has to be screened at all of their visits in order to be counted as a patient that was screened for TB. And it has to be documented because if it's not documented, again, that patient is not counted.
Correct. So we have an attendee who is asking for you to both share a little bit on the TB HIV co-epidemic in terms of what's the epidemiology.
Okay, so the last data that TB would have provided, we were standing at 20% in terms of the prevalence amongst the disease. During the last year, they would have reported approximately 10 NDR TB cases that they're now working with. And in the last year, we would have accounted for 168 persons who were HIV positive and co-infected with TB.
Right, and I don't know if this will add to what Dr. Moore said, but that in addition to screening HIV positive patients for TB, I know that the TB program is very active in screening TB patients for HIV. And they do have HIV testing available at the TB sites. And maybe Dr. Moore can say what was the last TB HIV co-epidemic co-infection rates that have come up with from the TB side. But I know it was close to about 20% of the TB patients who were diagnosed with HIV. I don't know what's the latest data.
So the last published data is the 20% that doctor has referred to. I tend to not share the data that is not published, but this is what is verified data. The 20% was the last verified data that was published.
So we have another question from someone else who would like to know whether mortality in your patients with TB, if there is a disproportionate large group of people living with HIV.
Based on the last mortality data that was made available to the program, which was since 2015, I would have to say that that is no. Of the 9 patients that would have been accounted for as the cause of death being TB HIV co-infection, being TB, 4 of them were actually TB patients. So the other 5, HIV patients. So the other 5 were HIV negative patients.
Okay, I can understand the question, and I wonder if it's a similar situation that's happening in some of the other countries, and therefore that question was raised. because I think generally when we think about TB, HIV co-epidemics, we do think about them, TB being really a significant cause of death among our HIV patients. Um, at this point, I don't see any other question, or maybe I do. Oh yes, we do have a few more questions. So I have a question here that says to calculate the percent of HIV positive that were screened for TB at every visit. How is this information captured from the different sites? Do you maintain a central HIV register from which this is calculated?
So each site has its individual register in which it has to enter the screening information, and then through the site verification and monitoring visits that are done, that information is captured. That information is also reported on the reporting tool that I shared in the penultimate slide. And so the sites will also report that information from their data source or register at the site, but then a verification is done through visit to the site, and then that data is collected and aggregated at the national level.
Okay. I don't see any other questions from our participants. And so therefore I want to take the opportunity to thank Dr. Rhonda Moore and Dr. Ruth Ramos for sharing the experience, the Guyana's experience on TB HIV co-management, and for openly speaking about some of the challenges they encountered, even though they have so much to share in terms of what's happening. The really good things in terms of TB HIV co-management. I trust that this webinar has been useful, particularly for participants who are coming from a national program or from a context where TB HIV co-epidemics are significant. So, like I said, it was an excellent presentation, but it does bring us to the end of our webinar. And so on behalf of PANCAP, the Pan-Caribbean Partnership on HIV against HIV and AIDS, the director, Mr. Derek Spring, and all of our participants today, let me thank you again, Dr. Ruth Ramos and Dr. Rhonda Moore, for sharing with us this afternoon, for investing your time, sharing your experience and your knowledge with us and with the wider partnership. Thanks to all of you who have joined us this afternoon. As a reminder, as I said earlier, the webinar will be recorded and will be posted on PANCAP's website. I encourage you to join us at our next webinar, which will be on March 29th. And it's a really interesting topic. It's on HIV and histoplasmosis. So I encourage you to join. And finally, I encourage you to stay engaged with the regional response. Follow us on all of our social media platforms, Facebook, Twitter, and keep being engaged with the regional response. Thanks again, everyone, for staying with us, for submitting your questions, for engaging the presenters, and have a great day.